morning, everyone. I am Allison Herman, the care coordinator for the independent living residents. And thank you for coming. We have Ennoble Care here to share a little bit about themselves, as they're going to be our new primary care providers here on campus for the independent living residents. We have Christine Beck here, who is their Director of Growth, as well as Rob Loya, who will come up in a little bit. He is the PA and the provider that will be seeing residents here on campus. Ennoble Care, I've worked with them in the past for a few residents here on campus and have had great experiences as well as some great testimonials from other residents. So we're excited to be partnering with them to allow you to have that new option. So here's Christine.
Is this okay? Okay. Good morning. My name's Christine Beck, and I'm the Director of Growth for Ennoble Care. Ennoble Care is a primary care, hold on. Sorry, I'm trying to get the, there we go. We are a primary care slash internal medicine group that sees patients where they live. We do not have any brick and mortar doctor's offices. Pardon me? Oh, I thought someone had a question. We see patients where they live. And it's typically patients that have an inability to get out to the doctor's office, either due to disease process and a physical deconditioning, or maybe they're not driving anymore. Okay? So this is a little history about Ennoble Care. We have lead clinicians like Rob. Rob is a physician's assistant. He sees patients in their homes every 4 to 6 weeks, depending on the patient's condition and depending on what he feels is necessary for the patient. Our supporting clinicians are medical techs, and they work out of our home office in New Jersey. It's called a care coordination team. Excuse me. Okay, is this better? Okay, no problem. Sorry about that. So, in addition to a primary care provider coming to see you in your home, that would be Rob as a physician's assistant, or we also have nurse practitioners that work with us that see patients out in their homes. We have a support staff, and that staff is called a care coordination team. It's a group of medical techs, and their role is twofold. It's to support the provider in the field, like Rob, and it's also to support patients. So what that looks like is the provider comes out and does a physical examination on a patient. They identify needs the patient may have. Maybe it's home health services. Maybe the provider feels a patient could benefit from in-home physical therapy. Maybe the provider wants to get some lab work. Or maybe the patient has a need for a chest x-ray. The provider is there to oversee managing those needs and writing the orders for that, in addition to overseeing medication. The care coordination team is responsible for placing those orders and making sure that the services are brought to patients' homes. So as much services as we can bring into the home, we will bring into the home, okay? In addition to managing medications and ordering services to be brought to the home, our care coordinators will call patients in between our visits. They're calling them to check on symptoms, and they're calling them to check on medication. We want to make sure, one, you have your medications, two, you're taking your medications, and three, you're taking them correctly. That's a very big part of what we do. We're asking about symptoms because many of our patients have multiple chronic conditions, and if a patient, let's just give an example, is having labored breathing, and they've kind of gotten used to it, so that's kind of their norm, and they think that's normal, it's not. We want to know about that Because if we need to make adjustments to medication, maybe we need to make adjustments to your oxygen. We want to make sure that we can head off that potential exacerbation of a disease process that could land a patient in the hospital. Okay? Our location is where patients live. We work within communities like Carroll Lutheran Village. We see patients in their homes that they've lived in for 50 years. We work in assisted livings, and we work in other like senior communities, independent living, just like here. Our technology infrastructure. We have our own electronic medical record. So if you are somebody that enjoys technology and would like to sign up for our patient portal, we can provide you with that information, and you can log in and create your own unique login and password so you can access your records from Ennoble Care anytime you want. Little bit of history. We started off in 2012 in Brooklyn, New York, as a house calls practice, just primary care in the home. It was a father and son. They started Ennoble Care. The son was the business mind. The father was the tech mind. He created our electronic medical record that then became certified by Medicare. In 2017, we accepted our first hospice and house calls patients in New Jersey. So we went from New York to northern New Jersey, and we have the full continuum of care in New Jersey. We have house calls, palliative care, and hospice. In 2018, we came to the state of Maryland by way of an acquisition. The company we acquired, I think Rob came with that acquisition, is called Capital Coordinated Medicine. It was a nurse practitioner that ran it, and she sold the practice to Ennoble Care. In 2020, we were awarded an ACO, it's called ACO REACH by Medicare. The whole goal, and I'm just going to explain this briefly, I can answer questions if you have them, but we are moving from traditional fee-for-service from Medicare to value-based care. And what that means for you as a patient is it's going to be more quality visits, more quality time spent with patients to manage their needs. 2021, we moved to the state of Georgia through a hospice. In 2022, we expanded our house calls practice in New Jersey by acquiring a company by the name of Phoenix House Calls. And in 2023, we acquired another house calls practice in New York and New Jersey. And we also just in 2024, in January, we opened a hospice in Northern Virginia. So we are a very young company, and we are growing and emerging. We focus on geriatrics. And in the state of Maryland, we do house calls and palliative care. We do not have hospice. That's our map so far. Appropriate patient criteria. As a patient, you don't have to meet all of these criteria, but this list up here gives a good idea of who we're treating. Most of our patients are frail, older adults with 2 or more chronic conditions that need to be managed. The reason for our visit frequency, like I mentioned before, is to head off that exacerbation of a disease process. So that's one of the reasons why we have this criteria is we need to be able to come and manage things for patients. We can't just come in and listen to your heart and lungs and skedaddle. We're there to actively treat you as a patient. 2, with frail older adults with chronic conditions who cannot access office-based care. Our services are wonderful. They're not for everyone. Some people can very readily get out to their physician's offices, and it's good for them. They've had these long-established relationships. That's healthy. The patterns that they're in are healthy. I know I've talked to some families, and they're like, well, I take my dad to the doctor, and that's our outing because then we go to lunch, and that's healthy. It's when that can't happen anymore that we come into play. Because we want to make sure that your needs are met. We want to make sure that you're healthy, that you're stable, and you're comfortable. We want to so that you can age in place. think anyone in this room desires to go to the hospital. So if we do our job, we're working really hard to keep you out of the hospital. Homebound patients, usually with one principal neuromuscular conditions such as multiple sclerosis, Parkinson's, spinal cord injuries. So it's very challenging for these patients to get out to an office-based practice. High-risk diagnosis such as COPD, congestive heart failure, hypertension, diabetes. This is what we really excel in, is managing these chronic conditions. Patients with a high hospital use. A lot of times if you kind of were to look at data and you peel back, why is this patient continually coming to the emergency room every 6 weeks? They're typically not going to their doctor because it's easier to call 911, have an ambulance get them there, than it is to get there. Maybe they don't feel good. Maybe they don't have transportation. So patients with a high emergency use, usage, that's patients that we can help with. The last bullet point here is post-acute transitional care management. I want to spend a couple minutes on this. So I'm going to give an example of a patient that's had a stroke and they've gone to the hospital. And let's say they're discharging and they still have some paralysis, but they have a great prognosis. But in that interim period, they're struggling, they can't get out to their doctor's office. We can help. So if you have a primary care physician that you've been working with for 20 years, which is very common, and you were to go to the hospital and with a life-altering condition, and upon discharge, your ability to get back out to community care is diminished. We can work with you for 60 to 90 days. In that time period, that's going to be at least 2 or 3 visits from Ennoble Care. And so I tell patients in this scenario, your goal is to get back to, we'll say, Dr. Smith over here. We'd like you to get back to Dr. Smith, but we know that right now you can't. So work with us, but solely work with us. I don't want you calling Dr. Smith for certain medications and Rob for other medications, because that puts you in a very dangerous situation. So work with us, 60 to 90 days. The end of that period, you make the decision. I'm feeling great, I'm mobile, I don't have paralysis anymore, I'm going back to Dr. Smith. You just asked to be discharged from Ennoble. That's wonderful. Or maybe in that time period, you've discovered this is a better fit for where I am, and then we stay on with you. Does that make sense? So I've talked about the post-acute transitional care, remote patient monitoring. We work with a company that has devices for managing chronic conditions. So let's just say you had COPD. We're going to give you a pulse ox. And we're going to ask you for a 30-day period to check your pulse, stick your little finger in the slot and check your pulse ox for 90 days. It gives a reading. It goes back to the company that we contract with. Anytime that the reading goes outside of the parameters that your physician has set for you, we get a call. The reason we use tools like this, like remote patient monitoring, it can be used for COPD, hypertension, CHF, diabetes. The reason we use tools like this is to get a better understanding of a patient's disease process. If we, the patient's calling all the time, I don't feel good, I feel like I can't breathe, I can't, putting a device in the home to really get an understanding of what's going on, maybe in the middle of the night their breathing goes really down. That could be indicative of something else, and the provider can look into that. But we want to use these tools in our toolbox to better assist in appropriately treating our patients. Telemedicine. I'm sure you're all familiar with telemedicine because of COVID. It's when you have a video and you're talking to your doctor online. We can do that. That's not our primary mode of seeing patients. We want to see you in person. But let's just say you're having an issue and you call us in between visits and it's the provider needs to address it right then and there, we can utilize telemedicine to diagnose and to treat you at that moment. Because if waiting a couple days is not in your best interest, we want to, again, another tool in our toolbox to help you. Family and caregiver support. From the first call to Ennoble, which many times is me, until you meet with Rob and our support staff, everyone that you're going to speak to is going to offer guidance and support. Navigating the senior care industry can be very overwhelming. I don't know how many of you have ever had to go to the hospital and then to a rehab and come home, and it's overwhelming. They're throwing lists at you saying, pick, 3 out of here, and no one's really taking the time to explain the services that you need to then get home and how to manage that. So at Ennoble Care, we're very good at directing our patients to the right resources. Palliative care. Palliative care is a very gray area. If you were to kind of look at pretend I have a line here, and here is a patient, and this is pre-diagnosis. So they're seeing their primary care physician maybe every quarter, okay? And they're just doing their regular Medicare physicals every, I think, 90 days. And then they get a diagnosis of congestive heart failure. And they're doing well. The physician is very well managing the condition, and over time, just due to the natural aging process, it gets more challenging. And it gets more challenging to treat the symptoms and to treat the condition, and you start declining a little bit. And you get into this gray area where you're not hospice appropriate because you have to qualify for hospice, and you're not ready for hospice. You want to live your life. So there's this area called palliative care. And what palliative care is, it offers symptom management to patients. It offers comfort measures as far as like if a patient was experiencing some pain that was coming in due to a disease process. So the palliative, when you're receiving palliative care, it's very similar to our primary care in the sense that the provider is providing these services to you. They're managing your conditions. They're probably managing a little bit more from the palliative perspective because now all the side effects of the disease process and all the medications used to treat the disease process are now coming into play. So if you still would like to seek aggressive treatment for a condition, you can certainly do that with palliative care. And then when patients are nearing more of the end of life, that's when hospice becomes appropriate. God bless you. The care management, I've already talked to you about. There are med techs that work remotely out of our home office in New Jersey. Behavioral health. We do offer a service called behavioral health integration. It is we call it a wraparound service for our primary care patients. So it's just another support that we have in place for our patients. To get this service, a patient has to have a qualifying diagnosis. A couple of examples of a qualifying diagnosis are dementia, depression, panic, anxiety. Those are just to name a few. If you talk to your primary care provider and they've identified one of these diagnoses and you're interested in the services, they would write an order for our behavioral health team. That's a group of social workers. Right now, they are all masters of social work. Our program we are growing the program, so it's still in its infancy. All of them are now studying to get their LCSW, which is a licensed clinical social worker, so they can do therapy. So the visits here at CLV, I believe, would be in person because our social workers are coming to communities. If a patient lives in their own individual home, the visit would be done telephonically. But they're there to support patients. They're there in crisis times to educate them, to connect them to community resources. They're also there for the patient's caregivers. One of the greatest examples that I've been given is, we had a patient lived with her adult daughter, the patient had dementia, and the adult daughter was not really prepared for what that looked like when mom moved in. It was very, very difficult. So the social worker was working with the daughter to help her understand mom better, which made their relationship better. And also to give her some, tips and tricks on how to best manage when mom had these outbursts. So that's our behavioral health team. The value-based approach. This is what I was talking about. Traditional Medicare is, I'm sure you've gone into your doctor's office and they book appointments every 15 to 20 minutes. And you're sitting there, and you're sitting there, and you're sitting there. They have a lot of patients to see in a very short period of time, and unfortunately, you're not spending a lot of time with your physician. We're moving away from that. We just started tracking our ACO data, and the results have been really good. We have a 20 to 25% lower hospitalization, inpatient utilization and spend. So what that means is, as compared to traditional Medicare fee-for-service patients with the same conditions, we're managing them better and keeping them home. We're keeping them out of the hospital. Our patient hospital readmission rate is 27% lower than patients with similar risk scores. So if you're looking at apples to apples, your risk score would be if you had the same diagnosis and your office-based care versus home-based care in a value-based approach. A 22% lower home health spend. So we are ordering home health for our patients, but our patients are doing quite well, so it's not as needed as with traditional office-based care. And our SNF, a SNF is a skilled nursing facility. The admission rate is 53% lower than patients outside of our ACO. And our emergency department admissions are per 1,000 are 17% lower. So the value-based care, it offers us some more tools, it offers us more time with patients, and it offers us, with the care management piece, with the behavioral health piece, it offers us a lot more to best manage patients. That's me. For anybody watching this streaming, if you have questions, please jot down my name and phone number. I'm happy to answer any questions that you have. And now I'll take questions from the audience if anybody has any. Yes. Insurance, good question. So on the sheet that I gave you, it has a list of the insurances that we accept. I would need to actually run the insurance to make sure, so even within those plans, there's a lot of different plans. Every insurance is unique to the patient and the insurance company. So we just need to run the insurance to make sure that we're in network. Yeah, we are not in network as a primary insurance. We can accept it as a secondary, but we are not in network with TRICARE as of yet. But I'm sorry? I know that they're working on some more contracts with other payers. We bill very similarly to a brick-and-mortar doctor's office. And the reason I say similarly is our billing codes are different because they're home-based care versus an office-based care. However, what that translates to you as a patient is the costs will be the same. So if you have Medicare Part B and you go to your primary care's office, the bill you get is, let's say you've met your deductible for the year for the Med B part, and then it goes to 80% coverage and you're responsible for 20%. So you're gonna have to pay the copay and the 20%. If you have a secondary, they can apply that and see what the secondary will do. We do the exact same thing. So there's no travel fees, there's no hidden fees. I can't tell you exactly what costs are associated up front because your insurance is so unique. So we have to go through a billing cycle and see. But I will tell you, we only bill to insurance. We don't accept private pay. So the only time you would get a bill is for the portion that your insurance does not cover, which would be the same as if you were going into an office.
My major concern relates to my dealings with United Healthcare and MDIPA. The physician I see has to be approved, primary physician, has to be approved by actually United Healthcare.
Okay.
And also, secondly, I also have a copay of $25 every time I see the physician.
Okay.
Do you handle that?
Well, the first thing is we would have to run the insurance and see if it comes out that we are in network. And then we would have to, I would work with our billing department on that one because this sounds like a very unique situation by having to get approved. So it would just, we would have to kind of run it, see what they say, and then go from there. Yes, you would get a billing statement after each visit. We take care of all the billing.
Now, I do not have Medicare Part B.
Okay.
At all. This is my primary insurance.
Is it a managed
United
Medicare?
Healthcare.
Is it a managed Medicare product or just, is it a managed Medicare through United Healthcare?
But like I say, I have the copay, which is paid every time I go see a primary physician.
Okay.
Right now, and basically they have certain guidelines that I have to follow.
Okay. So we would just need to run it and see if we're in network.
But with actually, with it not being a secondary, like for Medicare Part B and A, it to pick up where Part A does not pay, and then if I go to that doctor, picks up all the medical expenses. Which can you do that? Take care of my primary physician.
I think we can. We would have to run the insurance is what I'm saying. I mean, it all comes back to seeing if we're in network and then seeing what guidelines your insurance company is asking us to follow.
Okay. I have to talk to you more detail.
Sure.
You need a doctor to join this?
Pardon me?
So if you could repeat the question is, do you take someone who doesn't have an existing physician?
Yeah, you don't need a referral you don't need to be referred to us is what I'm saying. If you would like to have our services, I'm going to encourage you to call me. My information is on there, and I'll get your information over the phone and put it into our system. The first steps is we check the insurance to make sure we're in network. Then the next steps is we have a consent form that needs to be signed. It's a consent to treat. So it's a legal document. It is not a contract to work with us. It's not a binding document. What it does is it gives us permission to perform physical examination. It gives us permission to work with other healthcare providers on the patient's behalf. And it gives us permission to bill to insurance. We do. Yeah, we have an electronic medical record, and if you would like to sign up for our patient portal, you can access it that way. Or if that's not your thing, anytime you need records, you would just call our office and ask for them. Does that make sense?
Any other questions?
Oh, right over here.
I have a primary physician right now, but I also I have 3 specialists that I visit, and my husband has 1. You know, how do you work with the specialists? If you know that I have specialists that I deal with, you know, does that information get handed to the person that comes and visits?
Yes. Yes. So
About like if they would send out any reports from my visits, that comes to you guys, that you know that as well?
Well, so for patients that work with specialists, we encourage you to continue working with specialists. You're with them for a very specific reason. We can collaborate with them as long as you connect us. So if you say, I have a cardiologist and I would like my records to go to the cardiologist, you let your primary care physician know that.
Okay.
And then our care management team will make and provide us with that information. That answer your question? Rob, do you have anything you want to add?
Okay, hold on, we got a few more
Oh,
questions.
sorry.
Do you see people who aren't housebound? I mean, people that just don't have a doctor, but they're mobile.
We can. We don't have to meet the strict homebound criteria that like a Medicare A home health agency has to meet. As long as the criteria, multiple chronic conditions that need to be managed. In a senior living community, we see patients all the time, and they're very independent. The whole goal is to keep them independent. So you're not stuck to your house when you work with us.
Any other questions?
And here, actually, I think, we can see you in your home, in your apartment, or at the health center. It's, it's just whatever your preference is. Yes, so the way our system works is we typically see patients every 4 to 6 weeks, provided nothing's going on, but it's also up to the provider and the patient, like patient's condition from a clinical perspective. And if the provider feels like, you know what, you're doing really well, I can see you in 8 weeks, that works. Once we get it's probably more than you need to know, but a volume of patients in a community, and that number would be like maybe 15 to 20 residents, we can be there weekly, but for individuals, the visit frequency is roughly every 4 to 6 weeks.
Just once a month?
Yes. Yeah, an individual patient, our system is designed around seeing them every 4 to 6 weeks.
And if you have trouble during this 4 weeks, we can call you?
Absolutely.
And
I
something.
provide everybody with an information sheet. It's a contact sheet. One, it has our scheduling office number, so you recognize it, because we will call you to schedule your appointments. 2, it has our care coordination number, because that's the number that you'll call when you're not feeling well, and you'll get in touch with your provider. And then I give you our website, too.
For the orange lady.
What's the turnaround time for sick visits? Like if somebody gets up in the morning, how quick can they be seen?
That is, it's not a really super direct answer. So I'm going to provide our care coordination number, because I want you to call your provider. They're going to kind of triage it on the phone and determine the best course of action for the patient, whether they can get out there in a few days to see them, whether it's, an emergent situation and they need to call 911, or if we can do telehealth or telephonic to address the need.
Okay, thank you. Yeah, and we do have the urgent care also. But, if Rob is coming here really frequently, I guess he would still, our patients or residents who are seeing Ennoble, they would still call the main line, right?
Yeah.
And they know where Rob is. Can he
they'll
run in and
connect
see
them.
somebody since you're already here? Wondering if that's possible as an option.
So down the road, and this is something we talked about, I can get more into detail with you about like
Okay.
clinic visits. That's something down the road.
Okay. Right.
Okay. Anyone else? One. We can see patients individually. The reason.
Question. Yeah.
So her question was, how many takers does it get to get started? And I said, 1 patient. Remember, we're a home-based primary care provider, so we see patients where they live. So for us to be here maybe on a weekly basis, we would need about 20 patients on service. But as an individual, we can still see you. Anyone have any questions for Rob? Oh, I'm sorry. This is
Hello.
Rob Loya. He is our physician's assistant,
Hi.
and he will be seeing residents at Carroll Lutheran Village.
Anybody have any questions for me? So I've been a physician assistant since 2010, 2008. Sorry, 2008. Started in emergency medicine, and then have been doing this probably since 2016. So I've been at this for a while. I go to assisted livings. I go to patients' houses. I've seen a couple of residents here at some of the independent places here at Carroll Lutheran over the last few years. And I do live in the community. I live here in Carroll County. But yeah, I've been in medicine for 34 years. So I've been in all sorts of avenues of it, from phlebotomy to pain management to med tech, everything. I did 5 years in the Navy, so hospital corpsman. Yeah, so medicine's been my thing. Any questions? Yes, ma'am. Yes, ma'am. I live in Westminster. Well, not right this second, but yes.
Do they contact Allison or contact a number here if we're interested?
You can call me. My number is on the sheet.
Or the other sheet?
Yeah.
Okay.
Call me directly if you're interested. Our intake department is wonderful, but I will remember presenting to you, and I'll walk you through everything, and I'd like to be able to send you all the documents. And if you can't get our consent form electronically, I'll come meet you and get it signed. Okay? Any other questions? No? Well, super. Thank you all so much for coming, and thanks everybody for tuning in. I'm available, as well as Christine. If you have any other questions, feel free to reach out to me or stop by my office, and I'm happy to guide you. Just call me and I can get your information over the phone. All right. Thank you all so much.